Okay, welcome everybody. Uh, this one was requested by a couple of people and the request was affirmed by several others. As I said, this is not normally part of an electromagnetic fields class, but certainly we're all living in the days of the virus, and certainly ventilators and intensive care unit medicine have been in the news. There are a lot of engineering groups that are working on emergency equipment to try to keep hospitals supplied. Ventilators are the main capital item of the anesthesiologist and of the intensive care unit patient care station. The United States doesn't have that many. The numbers work out to about 25,000 of them across the United States. And I have to admit, at the beginning of this, I was surprised to hear that number. I had been figuring that we had 4 or 5 times that many. Not all the work. So there are a lot of university groups that are doing emergency design and emergency manufacture with 3D printers and hacksaws and paper cutters and whatever else is available. Some of you may be involved of it. Some of you may hear about it and want to be involved. So I want to give you some background here. And I want to say a few words about what you should be doing. Ethically, morally, practically. So let's talk. All right. Ventilator. This is the fundamental piece of equipment for the intensive care unit. To stay alive, you got to pull air into your lungs and you got to push it out again. You got to do it about 10 times a minute. You need oxygen in, you need carbon dioxide out, and it requires energy over time, power to breathe, just to push that air in and out. Now, the oxygen that you bring in flows passively down a concentration gradient into your blood. We'll talk a bit about that. But you have to get the bulk air in. It takes work, and not everybody who's critically ill is up to that much exercise, is up to the task. So ventilators remove the work of breathing from a critically ill patient. They are a medical device, they're invasive, they have their own set of harms, some of which are irreversible. I'm going to emphasize it again, the basic underpinning of any system of medical ethics, primum non nocere, first do no harm. First, do no harm. I had a professor when I was an intern who said to me once, you know, of the mass of people out there, there are a couple we can make better. There's a small number we can make better. There isn't a single one of them out there we can't make worse. So be careful. Primum non nocere. All right, positive pressure ventilation. The squirting of air under pressure down someone's windpipe goes way back. Maybe it is the first recorded medical procedure. The next one, of course, being the induction of general anesthetic for Adam's rib resection. But at any rate, the idea that airway comes out to face and that you can push air down it rather than the person pulling air in is old. I did have to laugh at this, that apparently even for the very first version of this, there was an item of personal protective equipment used. However, when I was an undergrad taking my first CPR course, we were still taught direct contact mouth-to-mouth resuscitation. And that's pretty much gone. It's not even part of CPR anymore. I do recommend that you take a CPR course. What for providers is called basic cardiac life support. It's true, you may save a life. Take it with a friend. The life that gets saved may be yours. It doesn't teach mouth-to-mouth resuscitation anymore. But the next version of the class, the advanced cardiac life support, does teach ventilation by mask. What does a mask do? What's in the provider's right hand is a pressure bag arrangement. It's fed by oxygen. You can see a small loop of green tubing there. That's bringing oxygen into this reservoir. The mask provides a tight seal around the patient's face. So the patient's airway is essentially brought out of face, mouth and nose, attached here to a pressure tight fitting, and is able to be pressurized by oxygen. This picture is more than a few months old, so even here, they're not wearing gloves. And times are changing. Everybody's going to be wearing gloves for this sort of thing, and they are already. Now, the ambu bag, it's a trade name for the kind of positive pressure ventilator that you saw in the previous picture. It's one of those excellent pieces of engineering. It just does what you expect it's going to do. Someone hands it to you, says form a seal and squeeze. You squeeze. You watch the patient's chest go up when the air goes in, you let go. You watch the patient's chest go back down as the patient exhales. Okay, you squeeze again, you let go again. It just does what you expect. It's subtler than that on the inside. The valving of this is really quite involved and is an extraordinary piece of engineering. It has to have the main self-inflating bag that you squeeze on. It has to have a reservoir bag to hold oxygen that comes in from the oxygen inlet and the oxygen tubing, which will connect to oxygen under pressure. The oxygen connects here, fills this bag first, fills this bag second. The valving is arranged so that even while the patient is exhaling, the oxygen may accumulate in these two bags. If enough oxygen is available at a high enough flow rate, these two bags completely. If there isn't enough oxygen to fill them completely, this bag will fill the rest of the way with air. It will pull whatever oxygen is available here. These valves will permit air to go in if there isn't enough oxygen here. These valves permit expiration asynchronous from the filling of this. It's really quite an extraordinary set of valves and volumes. It's worth studying, and I never could convince my trainees to do so. Okay. The automation of ventilation is a somewhat different story. The first automated ventilators didn't do what I just described. This is a negative pressure ventilator, the iron lung of the polio era. This was set up for patients who were basically otherwise healthy, but had lost their muscles of ventilation, couldn't draw a breath. This system had an advantage over the intubated system that the patient's face was clear, the airway was open, the patient could talk, the patient could look around. It wasn't a pleasant life, but if you didn't need it for terribly long, you could survive. There were glove box holes on the side that permitted a caretaker to provide bodily care to the patient. The total engineered system of a ventilator, like many things in biomedical engineering, and really like many things in engineering overall, many of the tasks that you are going to be given as an engineer will require you to make something that fulfills a need for something else. Even if you design a video game, you're going to have to design buttons that are of appropriate size, shape, and color to be pressed by the player's fingers. The springs behind them have to be of appropriate spring constant so that the person can push the button without having to stand on it, or that it won't push so easily that there will be a lot of false inputs. Human factors design, and in general, the making of one engineered good to match the specifications of another is a basic task of the engineer. Here, the ventilator system has to match measured physiologic variables and parameters of the entire respiratory system of a human being. In order to talk about the ventilator, we have to talk about this first. Physiology generally is the more interesting topic for the engineer, but you can't really get to the physiology without talking about the anatomy. So let's talk about anatomy a bit. The entire lung system has conducting airways. This is the trachea, the largest of the conducting airways. It branches at the carina, Greek for keel, into two main stem bronchi. Each one goes to one lung. They then bifurcate off multiple times into smaller and smaller tubes until finally the bronchioles, the smallest of the conducting airways, and they're conducting airways because they conduct gas, but they don't engage in gas transfer. There isn't motion of oxygen molecules from the gas in these tubes into blood. That takes place at these sort of bunch of grapes looking things at the end, which are enlarged here. These are called the alveoli. Each of them is only one cell membrane thick. This is the tissue thin, delicate structure of the lungs that is that gas molecules can pass down the concentration gradient, down the energy gradient, from the gas inside the alveoli to the blood that's on the outside. Now, I'll show you another slide of that next, but what I want you to see here is the topology of the system. The Inside of all of the airways, from trachea all the way down, is one topologic surface. In a topologic sense, all of the inside part of this, all the way down to the inside of the alveoli, is outside the body. The other side of the alveoli, the bloodstream, is where inside of the body picks up. So you have a complete topologic path from airway up here all the way down into trachea, and then by gas exchange all the way down into the bronchi. The alveoli themselves are dependent on thinness and on surface area for gas exchange. For oxygen to get in, for carbon dioxide to get out, and for those two things to happen fast enough that it's physiologically useful, you have thinness on the order of a couple of microns, and you have surface area on the order, I've kind of lost my screen here. If I close this, if I close that, I lose my cursor. And I would like to have my annotation cursor. There we go, good, okay. I believe I have 300 square meters written there, but it's obscured in my slides here. Now, important is that if they are working well, they're dried inside, and I see I printed that here twice, sorry about that. They have to be dry inside except for humidity, and they have to have full access to the blood flow around them. You can see in this schematic, the arteries are in red, the veins are in blue. The blue blood of the pulmonary arterioles, this is the only non-oxygenated arterial blood, meaning under high pressure, wraps around the alveoli into a fine, thin mesh network of blood vessels. It's in that mesh network that oxygen is picked up, and under lower hydraulic pressure, the oxygenated pulmonary venous blood is carried away, and that's what provides oxygen to all of your organs. It's put under hydraulic pressure by left heart. So I'll get my next slide there. More schematically, trachea bifurcates here into the left main stem bronchus, going down and down, smaller and smaller diameter to the bronchioles, to the alveoli. The pneumatic resistance structure, the pneumatic circuitry of the lungs, now is dependent on two main things: the diameter of the bronchioles, the caliber of them, and the elastic recoil of the alveoli. There isn't much resistance to pressure at the largest hoses up here, but as the hoses are getting smaller and smaller diameter, their pneumatic resistance goes up as inverse fourth power of diameter, but their length doesn't change very much compared to the length of the wider diameter structures. So most of the pulmonary resistance, the amount of pressure required to produce a given amount of flow, comes from here. The amount of spring resistance, the amount of pressure required to cause distension, comes from the alveoli. These structures don't much distend. The alveoli don't have very much pneumatic resistance themselves. So pneumatic resistance and the recoil of the lungs are going to wind up the two main mechanical determinants of how much pressure and volume are required from a mechanical ventilator. Now, the entire pulmonary circuitry, all of the gas exchanging conduits, all the parts of the body that do this, are illustrated here. We've been talking about the smallest things. They're so small that they're not illustrated here, the alveoli. Then the bronchioles coalescing into small bronchi, into a main stem bronchus, meeting up with the other main stem bronchus to trachea. Now in upper airway, where your vocal cords are, there's a bifurcation. Oral airway continues out here to mouth. So you have access to trachea from mouth along this path. You have access to trachea from nose along this path. And finally, in some circumstances, such as trauma or long-term requirement for outside access to airway, you have access along neck, straight out here, bypassing both mouth and nose. Vocal cords are here. So if an endotracheal tube, the plastic tube providing access to airway, goes through here, he can't talk. It's also quite uncomfortable. It's also quite uncomfortable. All of the mucosa here is very sensitive to foreign bodies. If you inhale even dust, you cough. If you have plastic in your airway here, it's painful or at least very uncomfortable, and it's stimulating of all of your reflexes to cough. So generally, the patient who needs this access is going to have to be anesthetized, made unconscious, or at least quite deeply sedated in order to tolerate it at all. The muscles of respiration are the next anatomic issue. There isn't any equivalent in trachea to the peristaltic motion of intestines. Intestines have a muscle layer, has coordinated squeezing that causes food to be propelled down the tube. There isn't any equivalent along your neck that squeezes air down. I'll show you the mechanism by which muscle contraction causes your lungs to expand. It's a little counterintuitive. It may not be the mechanism that you would consider it to be. And I'll point out too that expiration, getting air back out your mouth, getting ready for the next breath, is a passive function. Except right at the end of expiration, you don't have nearly the muscle action to squeeze air out as you do to pull it in. Most of expiration is passive. You let muscles relax and the air just comes out of its own accord. Well, here is a little toy model of how diaphragm, the main muscle of inspiration, works in the anatomy of the lungs. This bell jar has a stopper in it that is open to the atmosphere above. You can't see the opening in this picture, but there's a hole up here. It comes down, it bifurcates. There's a balloon attached to either side of the bifurcation that is our model here for the lungs. The diaphragm is the yellow sheet of rubber that is hose clamped to the bottom of this bell jar. The bell jar is tipped over here so you can see it better, and there's a handle attached to it so a demonstrator's fingers have an easy way of attaching to it and mimicking the muscles of the diaphragm. So what's in the space in here? This is a sealed space. It's mimicking what's called the pleural cavity. There is a membrane around lungs. There's a membrane around this whole structure here. The space in between is under a small vacuum and doesn't have any gas in it. So if the parietal pleura, the part that is connected to the rubber diaphragm here, is pulled on, this volume distends, and the only place that pressure, that reduced pressure of the distension can be relieved is by these balloons filling. That's the basic action of taking a breath in. The diaphragm muscle contracts and pulls out. The space between diaphragm and lungs has a vacuum induced on it. That vacuum gets translated into a distension of lungs, and lung volume increases by pulling gas from mouth or nose at atmospheric pressure in. So breathing is an action of negative pressure, of subatmospheric pressure. The boundary condition for the mouth, the glottic pressure, is that that pressure is atmospheric. In a somewhat more anatomic picture, this is your back, your spine, this is your front, your ribs. Your ribs do have muscles that are involved with respiration, but primarily it's diaphragm. The way diaphragm is inserted across all the bony structures here is that if the muscle contracts, it goes down. These arrows show the direction that the diaphragm in net moves as it becomes tense. The vacuum space is the black here. The lungs can slide freely in it, but it's a liquid-filled space, not gas normally. There is such thing as a pneumothorax, but that's a pathologic situation. The lungs expand, air is drawn in, that's an inspired breath. When the diaphragm is relaxed, it goes back up, the volume is reduced again, the lungs have elastic recoil. The lungs tend to collapse the same way that a toy balloon does. That's the expiratory force. Now, the polio victim's iron lung, the device that we showed earlier, it was the first attempt at mimicking natural breathing, at providing relief from work of breathing. The patient was inserted bodily into a steel tank, looked kind of like a household hot water heater. There was a stiff rubber fitting around the patient's neck. So now the patient's head, oropharynx, nasopharynx are in the atmosphere and at atmospheric pressure, at zero gauge pressure. A separate volume is defined inside the tank. A rubber diaphragm here is moved by an electric motor. As this diaphragm moved to the left, pressure inside the tank went subatmospheric, negative gauge pressure. Pulling on abdomen and diaphragm, that mimicked the function of the diaphragm itself and caused air to be pulled into lungs. After a fashion, it works okay, but you have to be trapped in this machine. It can't provide very large volumes or inspiratory pressures, and it is large and expensive. This fell out of use. It has a couple of isolated uses still, but even for polio patients, it's not of any great use. And I'll point out, the patient has to be in pretty good health shape otherwise. The issue of polio is that the muscle use wasn't there. So this took away work of breathing, but it doesn't have a way of providing high concentration oxygen other than just some mechanism of spraying oxygen on the patient's face. And it doesn't have a mechanism for providing airway pressures above the difference between atmospheric pressure and the pressure in here as reduced by all the massive abdomen and muscles. So on the order of 5 to 10 centimeters of water pressure is the extent of the pressure difference inside to out that could be achieved. In a sick patient, it's not enough. In a COVID-19 patient, it's certainly not enough. Well, positive pressure ventilators then started to come into use in the 60s in operative settings and in the 60s and 70s in intensive care unit settings. The first of them is that bag and valve ventilation apparatus that we talked about, the one that we said is actually a fairly subtle engineering achievement. What it provides in a positive pressure ventilation setting, it's shown here with a mask, but you can put a tube into the patient's trachea and permit direct connection of that tube to a positive pressure apparatus. That's the break point in this therapy. That's where arbitrarily controlled gases can be put in at arbitrarily controlled pressures. So let's take a look at that process. The tube itself, the most common type of these, is a polyvinyl chloride tube. It is large enough diameter not to provide much resistance to airflow, although necessarily it's narrower than the trachea is. It has a tube long enough to go into trachea and come out the patient's mouth or nose. It has a balloon here, the cuff, that can be inflated by this line to a spring-loaded one-way valve that connects to a standard syringe. It's called a Luer fitting. Has a valve here, so air can be instilled from outside the patient's mouth into the cuff. Now, that cuff is what will provide a ring seal from the inside of the patient's trachea all the way to the inside of the tube. The standard 15 millimeter connector here is a taper fitting. Smooth tapers turn out to be tight. The coefficient of friction of the material determines the angle of the taper required to give a press fit. But if it's smooth, it can be made gas tight to remarkably high pressures on simple insertion. It doesn't require any threaded screw. So this is an engineering standard, and I have a click to the standards for this. Here's the anatomy of the endotracheal tube itself. The tube has gone into the patient's mouth. This diagram doesn't include the taper fitting. It goes into mouth, it goes past epiglottis. That is the flap of tissue that during swallowing protects airway from food going down esophagus, down into food tube, the one back here. So this tube has to make a fairly tight turn past epiglottis, past vocal folds, so you can't talk. I'm going to keep my finger off the mouse pad here. Fairly far down trachea to end right at the bifurcation of the bronchi. The balloon is here, and again, when it is inflated, it provides a ring seal so that in effect, the gas space here has been brought out the patient's airway to the taper fitting. Here's a closer look at the ring seal of the cuff. If the cuff is inflated too much, it will have pressure on the inside mucosa of the trachea and can cause death there, can cause necrosis. So the tube has to be closely monitored. It can't be kept in forever because it puts pressure there and the blood vessels get closed off. But for up to about a week, this is an appropriate way to keep a patient connected to a ventilator apparatus. I have a click here for the engineering standards of the tube, and I do encourage you to read these things. It's interesting how tightly designed standards have to be for interchangeability. Well, that's the airway. It has been brought anatomically out of the patient and is sticking out, ready to be connected to some piece of equipment. That's your task, engineer. You get the airway now. Well, what does a ventilator actually have to do? For each inspiration, your piece of equipment will have to provide gas that has the correct mole fraction of oxygen, the correct mole fraction of nitrogen, might need to have other gases, in particular helium. Helium has a property of having low density and low viscosity, so it may be able to stay in laminar flow under conditions of bronchial swelling that nitrogen can't dilute oxygen for. There may be, excuse me, there may be anesthesia drugs included. We don't use ether anymore, but the contemporary versions of ether are gaseous drugs. And it has to be humidified. Otherwise, the inside of the trachea can become so dry that it crusts over and causes yet more restriction of caliber. This gas has to be provided with appropriate timing. We said before that you take a breath about every 10 seconds. The way the timing works out, about the first 1/3 of each 6-second cycle. If you're breathing 10 times per second, you're breathing once every 6 seconds. The first third of that, so about the first 2 seconds, is inspiratory time. The next 4 seconds, the rest of the cycle, is expiratory time. So for 2 seconds, you have to get enough pressure and flow rate into trachea, into your tube, to provide appropriate volume. What's appropriate volume? Typical numbers are about 10 cc per kilo of body mass. I weigh about 70 kilo, or I have mass of about 70 kilo. I need about 700 cc in 2 seconds for each breath. It's a remarkable amount of flow that's required. Yeah, about, yes, a little less than a liter. Yeah, okay, I haven't done this for a little while, so I want to make sure this is working out. And then finally, for expiration, there has to be a path out of low resistance to atmospheric pressure. Now, it may be that you can vent your patient's exhaled gas to the atmosphere right there. If your patient's otherwise healthy, isn't spraying out COVID virus, isn't spraying out drugs, the anesthesia drugs, then an ICU ventilator can vent right out to the room, and it isn't a hazard to anyone there. But it may be that it has to be actively evacuated and brought outside the building for infectious causes, or it has to be trapped and processed for pollution causes. So that ambu bag didn't. It just ventilated to the air where your face, more likely my face, the intubating physician, is. I may not want to inhale that gas. So you may have to be designing systems that have active gas scavenging. Now, I've been talking for half an hour here. If anybody wants to speak up with questions, please feel free to push the mic button. Otherwise, I don't have the chat window in front of me. Let me know if you have something there you want me to read. And this slide set is uploaded. Here are some typical curves. I won't get into them in detail, but they describe the airway pressure versus airway flow for an inspiratory cycle and an expiratory cycle. The inspiratory part is this. This is beginning of an inspiratory period, the end of an expiratory period. Pressure is brought up fairly quickly and then maintained roughly constant with this particular ventilator. There are different strategies for doing this, and it may be a delicate tuning to the patient's physiologic needs, what's best. We'll talk about what some of the definitions of best are, what your control system needs to optimize. But here we have relatively constant pressure. As lungs are inflating, the rate of increase of volume, otherwise the flow, is decreasing. Finally, when the preset volume is gotten into lungs, the expiratory phase begins. The lungs are at their maximum pressure right now, so there is an exponential decay, and the exponential time constant is pretty quick for the elastic recoil of lungs to push gas back out trachea until the end of expiration. And then the cycle begins anew. This is the beginning of inspiration. This is also an inspiratory, expiratory cycle, but for a slightly different ventilatory strategy, and I won't get into it here. If the patient's otherwise healthy, in all honesty, you can get away with a lot of different strategies. There isn't that much to optimize. But why might you need to have an otherwise healthy patient on a ventilator? Well, you guys are all about 20. You might have some small surgical illness. You might have your appendix need to be taken out. You might have a mole that needs to be removed. You might have some superficial surgery that requires a general anesthetic. So most general anesthetics do involve endotracheal intubation. If you're otherwise healthy, it's pretty straightforward. And the anesthesia machine at core is a ventilator that provides drugs and does a couple of other things. So, okay, you'll be made unconscious with drugs that go into your IV. You won't be being intubated. It won't hurt in any way. You'll have the tube in. You'll have the drugs from the anesthesia machine that keep you asleep. At the end of the surgery, you'll be permitted to wake up. Just as you're waking up and are breathing by yourself, well, the tube will be removed. You might cough once, but really that's the worst of it. What happens if you need to be intubated because you're medically ill? Can be a different story. The current picture with the coronavirus is that this virus, for reasons known only to itself, it didn't ask us, and we don't have the opportunity to ask it. It happens that its point of entry into human blood is through lung tissue. This isn't my field of expertise. I'm not an infectious disease doc, but in my limited understanding here, the coronavirus attaches to a particular receptor enzyme, a particular receptor protein that sticks out of lung tissue. It's the receptor protein of an enzyme system, the angiotensin convertase enzyme, that is one of the other things that lungs do. Like your brain, you think of your brain mostly as thinking, but actually it's a secretory organ. Also, it produces hormones and does other stuff. Your lungs also, you think of it mostly as a gas exchange organ, but it has some other evolutionary tasks to look after. And it turns out that this blood pressure controlling enzyme is one of them. Okay, when that happens, the virus gets into your lung cells, and it does what viruses do in any cells. It causes an inflammatory response. Inflammatory responses in general cause swelling. You've all been there with a sore throat or inflammation of some kind. It also causes those exceedingly thin alveolar cells, the gas exchange cells, to become stiff. So you lose on 2 counts here for the pneumatics of it. The ability of the conducting airways to pass gas flow under low pressure is compromised because they're becoming smaller diameter. The ability of the alveoli to expand easily under low pressure is becoming compromised because they're getting wet and stiff. And then finally, they're getting thick because of that wetness. Thickness is what poisons movement of a chemical down a concentration gradient. So it's what kills gas exchange here. Well, the first two things here then require that in order to get gas into alveoli, you have to use higher pressures. In order to get oxygen through the alveolus, you have to use higher concentration oxygen. Both of these, in fact, are bad for people. And this is why you're reading about some people who get on ventilators and don't get off again. It's the ventilatory therapy itself that makes them yet more sick. This is a coffin corner of intensive care medicine. So let's talk about ventilators. How COVID-19 affects the body. Our spot here is the severe spot. The lungs have gotten stiff and they are not doing their gas exchange well. The full critical issue is beyond the ventilator problems. It's other intensive care unit medicine issues. But we're in here. The ventilator, its main function is to take away the amount of exercise that you need to be doing to move your muscles for respiration. We run about 150 watts total just to be alive, your basal metabolic rate. Need about half of that, a third of it, somewhere in there, just to breathe. So breathing winds up being the single biggest exercise that you need, even when you're relatively healthy, if you're just being quiet. In the conditions we talked about here, the energetics of breathing can become overwhelming. It's just exhausting to pull air in and out of your lungs. The main function of a ventilator then is to let an outside power source do that. In most ICU ventilators, that's done by electric pumps. There's some interesting ones that we'll talk about where the power source is the compressed gas itself, the 50 psi oxygen. 50 psi oxygen, it's enough to inflate your car tires with. So you had to give power to the oxygen, you had to run a compressor to get it into the tank, but then it does provide an energy source all by itself. Compressed gas is an energy source. I won't go into this slide in detail, but it gives a quick view of what the machine does. This patient is shown wearing a mask. Pretty much the ones we're going to be talking about have the endotracheal tube in place. But there is tubing that connects the machine to the patient. Here is the outgoing tubing that is carrying oxygen. The outgoing from the machine to the patient. The tubing going back to the machine from the patient is carrying the reduced oxygen, increased carbon dioxide, and other contaminants air. The oxygen blender provides the dialed in concentration of oxygen. The pumping system regulates the pressure and the flow. There's humidification. The gas is bubbled through water so that the inner airways don't dry out. And there's a sensor and monitor structure that, in part, what's shown here mostly is electrocardiogram. So in part, it's monitoring the patient, but really much of it is monitoring the electronics of the ventilator. The ventilator has to have its own fail-safe structure. Let's take a look at a schematic diagram of an ICU ventilator. I'll give you a moment just to roll your eyes over this, and then I'll describe some of the separate parts. What do we got? Your engineered structure has to connect with appropriate physiology to the patient's lungs. So schematically, this is the endotracheal tube coming out of the patient, the connection to all of the engineered parts. The very first line here is a thin tube that samples the gas at the patient's airway, essentially at the new artificial mouth here, to do chemical analysis of it. This is the analyzer. The line here is indicating the signal path from the analyzer to the alarm system and the displaying computer displays. And then that gas is returned to the breathing circle. The gas gets from wall oxygen and air and nitrous oxide, an anesthetic gas, through a blender system into the pumping and regulating system through a fail-safe valve to the patient. A flow meter, V dot, so first time derivative of volume, flow, goes to the alarm and display computers. This valve permits gas to go to the patient. but not back when the patient exhales, when pressure here is greater than the controlling computer is permitting gas pressure to be here. When the patient so all of the control structure of the ventilator is essentially connected in here. This is where volume settings and pressure settings and gas concentration settings are coming from. This is the gas delivery equipment. The patient's exhale gas goes out here to this valve. Pressure and flow rate are reported to the computer here. There is a setting for maximum exhaled pressure that can be set in here and in the automatic pressure limiting valve. The patient, in this system, the patient's exhaled gas gets scavenged off to the building scavenging system, and so personnel in the area are protected from infectious and chemical hazards from the exhaled gas. This bag is a reservoir gas for the scavenging system, and there's additionally a negative pressure limiting valve so that in case scavenging pressure gets too much vacuum, that vacuum won't be presented to the patient's lungs. And there's a blower for the expiratory system, and there is a gas absorber in case complete circle breathing is desired. So it's a moderately complicated device. Ford Motor Systems is cranking up to do this. It's not as complicated as an automobile, but it's more complicated than a bicycle, let's say it that way. Learning the operation of it and all of its controls and fail-safes and settings, I'll say it's perhaps about on par with learning to fly a small airplane. It's not an airliner's worth. The entire intensive care unit setting is certainly more than an airliner's worth. But learning the ventilator itself is more complicated than driving. It's probably about like flying a small airplane. That's a full ICU ventilator with the monitors and the fail-safes and the gas blender and even some provision for giving drugs. At the simpler end are ventilators that aren't intended to be used for very long, transport ventilators. If you call an ambulance, you get sick at home, or if you're in a car accident, ambulance comes, the ambulance won't have a full-scale ventilator, but they will have some equipment, and many of the emergency medical technicians are trained and skilled in providing the kind of airway control that we've talked about. So there are ventilators that are sold for their purposes that are simplified in two ways. One is they don't have as many controls. There are not nearly as many knobs and dials on this one as on the intensive care unit and operating rooms that I showed you. Additionally, this one doesn't require any electricity. This is a fluidic system. It has its taper fitting to the patient connecting tubing here, but what you can't see is that in back, it has the proper screw-on fittings for high pressure oxygen and nothing else. There's no electric cord, there's no medical air under pressure screw-on fitting. So this entire thing gets its controlling power from the gas pressure only, and all of the switching is done mechanically. The change from inspiratory phase to expiratory phase, the timing between those, the time ratio between them, all of it. And what you'll notice here, pay a bit of attention to this one. It can set to 100% oxygen. Well, of course it can. It's connected to an oxygen tank, and that's what's powering it entirely. You can dial it down to about half oxygen, but you can't get it lower than that. This doesn't have a second tank of oxygen for a blender. It can entrain some air, and therefore nitrogen, to reduce the oxygen concentration, but only down to a limit. It still has to have enough total power source to run the whole thing. You can keep a patient on 100% oxygen for about half a day before the free radical production of 100% oxygen starts to cause medical problems. 50% oxygen you can run on for at least a couple of days. Eventually, unless the patient's oxygen needs overwhelm the other physiologic needs, and you're willing to tolerate the tissue damage of 100% oxygen, these ventilators have their time limit. Ford Motors is working with a manufacturer of these sorts of ventilators. It's light, it's made of aluminum, it is made mostly for air ambulance use, notice that an E-tank will only run it for about 45 minutes. If you have a patient whom you're ventilating with an ambu bag, an E-tank might run for several hours. This requires quite high flow of oxygen. An E-tank has 660 liters of standard pressure, atmospheric pressure oxygen in it, and this will riff through it pretty fast. It doesn't have any provision other than swapping off to an ambu bag for continuing to ventilate the patient if all you have available is room air. Well, if you're asked to help, what are the engineering requirements of a piece of equipment that is life critical? Can have point failures. At least the entire system into which it's integrated cannot have point failures. So you have to make sure that your instruction set to the skilled users who will be using this say you must have spare oxygen tanks, you must have an ambu bag there. You can't permit a failure of this ventilator all by itself to kill the patient. You have to have alarms. You have to have some fail-safe that notifies a skilled and trained operator. You have to have the protocols written. They have to be good. You have to have a training structure that signs off operators to do this. The materials have to be adequately strong. They have to be biocompatible. So your plastic can't be a poison to the patient. You gotta be able to clean it. If you're gonna use a virus patient intended piece of equipment more than once, you can't transmit virus from one patient to the next, or even from the patient to the people around it. Well, the big topic right now for folks who are living in academic engineering communities like us is emergency projects. We talked about the United States and the world not having enough ventilators. Here's one. This one takes an ambu bag, so it uses all of the safety engineering of a manual bag and puts it under motor control. They did a pretty good job with this. I got to give them credit. And I think the basic idea of using an established safe ventilator that will touch the patient being handled only on the outside by the purpose-built equipment is not a bad idea. This, though, is a statement from the group that did that, and the title click to their paper, that you got to use great care, and in particular, we recognize that this equipment can result in serious injury or in death. These are emergency desperate measures. Be careful doing them. There are groups around CASE doing some work. On the whole, I have to tell you, when they've contacted me for help, I've been discouraging of what they're doing. Some of the work going on is personal protective equipment for personnel. Some of that maybe is going better than the patient-attached equipment is. As you are asked to get involved, or if you seek involvement, you'll find some going on in ThinkBox. I warn you to be careful. Even in the days of the virus, enthusiasm itself isn't an adequate qualification for doing this work. The underpinning of any of medical ethics, any structure, is primum non nocere. First, do no harm. Be careful. If you need to simply say, I don't know, then say so. All right, that's my spiel for today. Next time we'll talk about electromagnetic waves some more, and I'm pleased to entertain questions for anyone who's still awake. I do have the, not in classical Latin, no sir. Yeah, but there are two different pronunciation systems. All right, I do have the chat window open now if you don't want to open your microphone, and I'm happy to stay around a bit after class as well. Folks.
Yeah, in church Latin, you're totally fine.
I appreciate that. Okay. Yeah, I opened with synagogue Hebrew, so it works out.
So Harry asks, can you speak a bit about the idea of ventilator splitting? I'm curious about this one too.
Yeah. This is like what you learned in 210 of a current splitting circuit. If you have two branches connected to one node, then it's a current divider. How does the current divide up? The pneumatic analogy of current here is gas flow. Without a control system that's going to have to be pretty good variable controlled pneumatic resistances along each of the branches, you're not going to have a match of pneumatic resistance from one branch to the next. Every patient is going to have a different shaped curve of airway pressure to airway flow. And keep in mind, the coefficient that links those two, the pneumatic resistance, isn't a constant anyway. There's a hysteresis loop for this. So I have to be honest, I am not enthusiastic about ventilator splitting. I'm not sure that anyone has made it work successfully in a real clinical setting, and anyone that does had better have a skilled clinician sitting right there between the two patients with separate volume and flow instruments on each patient, because you can't tell this by looking, making sure that everybody's getting appropriate ventilatory parameters. I have heard about it. I am skeptical. I'll leave it at that. Somebody? Hunter, are you
So
okay?
even in that idea of ventilator splitting, wouldn't you be increasing risk for cross-contamination pretty significantly by trying to split a single ventilator?
Yeah.
Or yeah, I don't know. I just not sure exactly how they're trying to do it.
Yes, I agree. It's worth remembering how viruses were discovered. In the late 19th century, the idea of filters that were small enough to filter out bacteria had already arisen, and such devices were being made. It was observed that there were some infectious particles that were getting through even those tiny filters. Bacterium is on the order of a half micron diameter. If something's getting through a half micron filter, it's pretty small. And those infectious agents were bacteria. So you'd have to have an extraordinary filtering system to do that. And I haven't heard a discussion of that. And I suppose the other side of it is that lacking a super infection, unless a patient with coronavirus has another infection going on, say a bacterial pneumonia, that there isn't cross-contamination to be had. It's kind of icky to be inhaling somebody else's exhaled breath, but at least you have the same virus. And that may be what's being depended on here.
All right, we've got another question from Ben. He says, how generalizable are ventilators and how problematic is it if you can't tune to each patient as you described?
The single biggest division, excuse me, is between ventilators intended for adults and those intended for children. There are some that can handle both, at least with some swapped out fittings like the bellows on the ventilator. But otherwise, generally pediatric ventilators are separate beasts from adult ones simply because of the control regime that they have to live in. Past that, even the transport ventilators that we discussed have nearly all of the appropriate parameters. They can provide enough pressure, enough flow, enough oxygen concentration for, I'll say broadly, all adult patients, meaning everyone above, I'll say this somewhat arbitrarily, 25 kilo. So most people over, say, the age of 12 or 13. For small children down to infants, generally a different piece of equipment is required, a pediatric ventilator. The Ford project, I don't believe, does include that. And I don't know what the nation's supply of pediatric ventilators is, how that shakes out. Sorry, I can't be more specific, but at least that.
All right, any more questions?
I'll do a verbal question for a change. Do you think there is a point where the sacrifices in maybe the education of people making solutions are appropriate when just the level of the number of deaths are at a certain point that you just need to try everything you can?
Yeah, it's a basic medical ethics problem. Do you take desperate measures just because they seem like a good idea at the time? I don't have an excellent answer for it. I don't have a single correct answer. Medicine has become less and less extemporaneous. Physician doesn't much these days try things on his own accord because it seems like a good idea at the moment. Even during my medical career, and I'm not that old, so many diagnoses and treatments have been worked out with real data behind them that you pretty much have to work at it to see something that someone else hasn't seen before you. I think we're in the middle of a good example of it. Not in the intensive care unit setting. One of the main questions right now is on the use of corticosteroids in these patients. It seems like a good idea because much of the pathology of the coronavirus is inflammatory. So, okay, shut off inflammatory response and see if that helps. The problem is the basic inflammatory response here has been studied pretty well over the past 30 years. It's the acute respiratory distress syndrome. And in the 80s, when this was first being well studied, the same idea came up and was well demonstrated to cause much more harm than good. Steroids don't have much of a place in ARDS treatment. Maybe there's something different about coronavirus, but it seems unlikely. So doing it without an overseen experimental protocol strikes me as problematic. I think similarly, having medical devices being built and deployed without appropriate oversight is problematic. The FDA is setting up a structure of emergency application and some form of emergency approval for some of these. I've been in touch with the University of Florida group, which by the way is almost entirely made up of ham radio operators. They happen to be anesthesiologists and other medical faculty at University of Florida, but they all have ham licenses. So all you guys, get your ham licenses. It's good for you. Christina's not even laughing. She's heard it from me too many times. Okay.
I'm laughing. I'm just on mute.
I appreciate it. Okay. That group is in their early form of emergency communication with the FDA. I got a call from them this morning, and they have been on the phone with the FDA, at least in a, hi, we need to get to know you quickly kind of mode. Most of their paperwork is going to be done this weekend on the telephone and perhaps getting a full approval over the next week or so. Now, it's an interesting story there. Their expectation is that deployment domestically would be to University of Florida only, and their further expectation at this point is that the University Medical Center there is going to be all right with their ventilators. They're not going to need any jury-rigged ones. And I don't think this group is saying anything other than that theirs is jury-rigged. If you're running your ventilator off hastily programmed Arduinos, you probably ought to step back for just a moment and make sure that you agree with yourself that what you're doing is a good idea. On the other hand, there are some genuine crises coming up. My guess is India is going to have a catastrophe. There is no way to do social distancing in a city like Mumbai. And it may be that having Arduino-controlled respirators essentially on the sidewalks is going to matter in a place like that. I'm afraid I'm giving you only an elliptical answer to your question here, but I'm doing the best I can here. Medical.
It was an interesting answer. Thank you.
Okay. And we greet Lydia. Can we have at least a hello back from the voyages? Lydia, I saw your microphone go back active. You want to say hi? Nope, Lydia shut her microphone back off. Well, greetings anyway, and we're glad that you're back here safely. For those who don't remember, Lydia was to have a 6-month sea voyage, and it got cut short because of coronavirus. I'm really sorry. We were all living vicariously through this one, and sorry you're back in the States. I hope you're well, and I hope everybody's well. I'm pleased to stay around, but if that's the end of questions, I am going to give my usual plea to everyone: stay safe.
All right, I'm going to stop the recording here. Thanks, guys.
Everyone, look after yourselves. For those who celebrated, have a peaceful and joyous Easter, and I'll see you Monday.